Good evening, and thank you for joining us tonight for the Infection Control and New RACGP Guidelines webinar. My name is Ayan Mejzoub, and I'm part of the Practice Support and Development team at Central and Eastern Sydney Primary Health Network. Also with us tonight from CESPN is Sara Madden. Sara is also from the Practice Support team, and she'll be helping in the background with questions. I would also like to welcome our guest speaker for tonight, Sara Drew. Before we begin, I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognize a continuing connection to land, water, and community, and pay respects to elders past, present, and emerging. I also extend that respect to Aboriginal colleagues joining us tonight. Now, I would like to introduce our speaker for the night, Sara Drew. Sara Drew is an experienced registered nurse with extensive background in primary healthcare, immunization, chronic disease management, and infection prevention and control nursing. She is currently the nurse program manager at APNA, the Australian Practice Nurse Association. Sara holds a graduate certificate in infection prevention and control and is an accredited nurse immunizer with strong interest in public health. Sara is passionate about supporting and strengthening the role of primary healthcare nurses through workforce development and education and raising the profile of primary healthcare nursing with undergraduate nurses. So now I'd like to hand over to you, Sara. Thank you.
Thank you for that, Aya. And again, welcome everyone tonight. It's great to see so many people joining us tonight. I think this is a hot topic at the moment, so hopefully I can give you some tips and tricks. So just before I start this evening, I too would like to acknowledge the traditional custodians of country throughout Australia and their continuing connection to land, sea and community. I pay my respects to them, their cultures and to elders past, present and emerging. So what are we doing tonight? There's a lot of information going to come your way this evening, but the presentation is being recorded, so please don't feel that you've got to be able to take it all on board. But we want to try and achieve a couple of things tonight. The first one there is for you to develop an understanding or an awareness of the revised RACGP and APNA Infection Prevention and Control Guidelines for general practice and other office-based and community-based practices. Try and say that in a fast way. We're going to identify some of the IPC or all of the IPC standards, guidelines and professional obligations that you have in this space. And we want to be able to recognise the infection prevention and control requirements for accreditation. We know that this is hot on the agenda of the surveyors. And, you know, there's a couple of good things that have come out of COVID, but I think this is actually one of them, and that is having raised the profile of IPC in primary healthcare. So what we're not going to do tonight is actually address the technical infection prevention and control inquiries. They're best directed to your infection prevention and control helplines in your states and territory, and also through to your PHN. So the team have got some opportunities to work with us to be able to support you to answer some of those specific questions. So I guess the reality is we're not focusing on those specific areas, but we really want to look at how does, or where is IPC targeted in accreditation to make sure that you are prepared for those. So let's start off by looking at the standards, guidelines and professional obligations that we have in this space of IPC. It is very confusing, and you know, people say to me, we don't know where to start. And if you look at this diagram here, you can see why that would be the case. We have the Australian Commission on Safety, Quality and Healthcare guidelines or standards. We have the Australian and New Zealand standards. We have accreditation standards, and for those working in general practice, that is the RACGP accreditation standards. We then have the IPC guidelines, and I'll talk to the name change there shortly. But the ones that we're referring to in this webinar tonight are for general practice, office and other community-based practices. We then have state and territory guidelines that we also need to consider into that spectrum. And then we need to produce our IPC manuals, which then hold our policies and procedures. So what does all this mean? So if we start at the top, we know that we have the National Safety and Quality Health Service Standards. And these provide a nationally consistent statement of the level of care that consumers can expect from health service organisations. So regardless of who you are, accredited or not, you must abide by these standards. The NSQHS standards were developed by the Commission in collaboration with the Australian Government, states and territories, private sector providers, clinical experts, patients and carers. So they cover the full spectrum. The primary aim of the standards is to protect the public from harm and to improve the quality of health service provision. Now, there's actually 8 standards that sit within the NSQHS. And they provide the nationally consistent statement about the level of care, like I said, that consumers can expect from their healthcare service. And it makes up the minimum care. Now, you can see the 8 there on the screen, but the one that's critical to us tonight is actually Standard 3. And Standard 3 talks to preventing and controlling infections. And so these were updated in 2021. So when we get to the RACGP and APNA IPC guidelines, you'll see that this was the document that we needed to make sure we were aligned to. So the Preventing and Controlling Infections Standard has been developed in line with the recommendations and evidence from the Australian guidelines for the prevention and control of infection in healthcare. You can see that on the screen there. The standard identifies that the most important element of a successful infection prevention and control program is a strong organisational structure which emphasises a commitment to a culture of safety that enables efficient monitoring of required IPC elements, reducing the risk of outbreaks. So there's a lot of big words in there, but the reality is this is our, the top level governance that we have in IPC. So what does this standard aim to do? It aims to reduce the risk of patients, consumers, and members of the workforce. So that's the critical bit. It's also us as members of the workforce from acquiring preventable infections, effectively managing infections if they occur, and prevent and contain antimicrobial resistance. They want to promote the appropriate prescribing and use of antimicrobials as part of the antimicrobial stewardship. And it's also about promoting the appropriate and sustainable use of infection prevention and control resources. So I guess, to put it in simple terms, this is Big Brother. And like I said, even if you're not accredited under the RACGP standards, you must meet these standards. So if we drop down to the next layer, we've actually got our Australian and New Zealand standards. And these are explicit statements of expected quality in the performance of healthcare activity. They're mandatory safety standards that specify minimum requirements that must be met. And they're introduced when it's considered reasonably necessary to prevent or reduce the risk of injury to a person. These standards set out specifications and design procedures to ensure that products and services consistently perform safely, reliably, and the way that they are intended. So you'll see on the screen there that standard, or the second standard that I've highlighted in bold, is the office-based healthcare facilities reprocessing of reusable medical and surgical instruments and equipment and the maintenance of the associated environment. I can't tell you how many calls we are getting at the moment since the release of the revised IPC guidelines around this standard. People are in a bit of a panic thinking that it's changed. It actually hasn't changed. And everything that we have in the guidelines is exactly what it has been for many, many, many years. In fact, since 2006. This standard, however, is currently pending revision, and it will be superseded by the new standard, which will be AS 5369, reprocessing of reusable medical devices and other devices in health and non-health related facilities. Now, just a word, the second that happens, we will make sure that you are aware. So please don't panic. Also, when a standard like this is changed, generally there's at least a 12-month waiver period where clinics can actually get up to date with the changes. In saying that, we've had standards where that waiver period has been extended on more than one occasion. So I guess my observation here is more around clinics haven't been abiding by this standard, as opposed to the fact that it's changed, because it definitely hasn't. But we'll go into that in a little bit more detail when we go through the accreditation standards. So then, of course, our next layer down is our accreditation standards. And for those of us that are working in general practice, we know that that is the RACGP standards for general practice. 5th edition is what we're currently under. Now, during COVID, some practices actually had their survey visits pushed back. And so there is some clinics that are still on that catch up. But generally speaking, everyone is now on the 5th edition standards. For those that join us from either allied health or community services or dental this evening, I have got in smaller print there is a couple of other standards that are applicable if you're working in those spaces or those specialties. So please, if you're not working in general practice, make sure that you're looking at the accreditation standards applicable to your sector. Now, we know that the RACGP has developed these standards with the purpose of protecting patients from harm by improving the safety and quality of healthcare. So you can see there, the theme keeps continuing all the way down from the top. And they're designed to support general practices in identifying and addressing any gaps in their systems and processes. And that's where your pre-assessment comes into place to support you through that. So here's the document. This is the one that's causing everyone panic. So the IPC guidelines for general practice and other office-based and community-based practices were released in November last year. They are nothing new. They're intended to help both health professionals in office-based practices implement infection prevention and control, but may refer them and support them in meeting the relevant criteria in the standards for general practice. So really, really important to note that while there has been some wholesale changes made when we've updated the IPC standards to guidelines, so that was probably the biggest change, was that name from standards to guidelines. The updated IPC guidelines do not implement new requirements that are not already in place by the standards for general practice, or the standards and the Australian New Zealand standards and the national guidelines. So we haven't changed anything through this process. It also doesn't change anything in regards to both your national and jurisdictional legislation that you need to make sure that you're covering. The update has consolidated and contextualised advice from these sources for general practice and other office-based practices. And we've added some additional details for practices throughout the guidelines to help you meet these existing requirements. The guidelines have also been developed as a web-based resource to ensure that we can update them easily, particularly when we have times of significant change like we've experienced in the last few years. For those of you that are aware of the previous version of this, it was a hard copy document that, we literally couldn't change. Something changed in COVID and, it would be emails. This way, we are constantly adding to it and building on it with any particular changes in IPC, but also as additional examples, for instance, come to hand, we add those in there. So just so you're aware, the guidelines were developed through 2022. It was quite a long process, I'll say. I think we started in March and we published in November. And it was the RACGP Technical Working Group. And it was funded through the Department of Health and Aged Care. And as a working group, we were made up of experts in the field of infectious diseases, microbiologists, infection prevention and control specialists, as well as doctors. There was a significant number of primary care nurses and practice managers in that working group. Probably the largest number of nurses that I have seen on a working group as such. The standards we initially mapped to the Australian guidelines for the prevention and control of infection in healthcare, which, like I said, had been recently updated to reflect the lessons learned during the COVID pandemic. The drafts we reviewed, and then we contributed to them by the working group. APNA took a lead role in that, as well as the Department of Health and Aged Care and other RACGP expert committees. And we then were able to produce the updated version of the guidelines that then was endorsed by RACGP, which was fantastic. Why did we change the name? We changed the name from standards to guidelines to better reflect the resource's purpose, because it is a resource, and to provide support to practices in meeting the infection prevention and control requirements. So it's not in itself something that practices are accredited against. It's the resource that supports you for your accreditation. And the guidelines, like I've already said, draw on the key sources that I mentioned previously. So it definitely is nothing new. The guidelines also very much focus on a risk assessment, risk-based approach and managing that risk. So if you put that lens across it, I think that takes a lot of the scariness away from what you will find. It also highlights the importance that all staff play in the role of infection prevention and control processes in your practice. And that's critical. IPC is not one person's role in primary care. It's not the nurse's role. It's not, your lead GP's role. It's not the practice manager's role. We need to play to everyone's strengths because it is a big job and there's a lot to cover, as we're going to find out. So what does the guideline address? Now, this is a real summation of I think we've got 10 chapters in there. And so the first one is the basics of infection prevention and control. And that includes principles, hand hygiene, PPE, which is a big one, aseptic techniques, and the levels of precaution. We then talk about managing risks of staff. And so that includes your staff screening and immunisation, including infection management. It includes sharps management and the exposure of blood and other body substances. We then go through managing your practice environment, and that includes cleaning, laundry, and waste management. The next one we look at is managing equipment. So the big one there obviously is the reprocessing of medical devices. We no longer talk about sterilisation because that's one step in the process of reprocessing reusable medical devices. We look at managing outbreaks. So that includes disease surveillance and outbreak response. And I don't think I need to talk to any of that over the past 3 years. We're all very well versed in that space. And we look at practice setup. So how can you ensure that your practice design is fit for purpose, what the fit out is that you use, and the equipment and consumables that you're using. There is a real push to single-use items and disposable items as opposed to reprocessing. So we can talk to that a little bit further. So once we've got in place where we're at in regards to, from a national level all the way down to being accredited against RACGP and utilising the IPC guidelines to support us in that process, we also need to consider our state and territory guidelines. And I've deliberately put every state and territory link on this slide for you. The top one, obviously bold, is the New South Wales guidelines. But, for those of you that may be on the border or that may, over time move into another state or territory, it's really about raising that awareness that, let me tell you, every state and territory has different components. I talk about air exchanges and isolation rooms in Queensland is very different to what we do in Victoria. So always make sure that you are checking in with your state and territory in regards to what are those local guidelines that you need to ensure that as you develop your policies and procedures, you are including. So we've got all our upper level information, and then we now need to transcribe that into our IPC manual, ensuring that our policies and procedures are actually addressing everything. Policies and procedures are living documents. They're not the sort of document that you do, sit, forget. and then accreditation's coming up 6 months out, we start looking at them. And I'll go into the role of your IPC leads shortly, but this is a really big part of your organisation. How often should they be reviewed, your policies and procedures? We get that question all the time. Now, the reality is it will depend on what the policy and procedures are. But, I would say that you should be looking at all of them on average at least once a year, if not more. But it does come down to your clinical governance within your organisation. And again, like I said, the changing environment that potentially exists in this space. So just keep that in mind. And like I said at the beginning, I can't reinforce this enough. The infection control involves all members of the team in order to improve public health and safety and limit the spread of infectious diseases. Like I said, COVID has brought about the fact that we are very conscious of all of these infectious diseases that present to us in primary care. And so making sure that you're across all of those health alerts and ensuring that you are putting in place the appropriate level of protection for your staff and your patients is really critical. And so it is very important that our front of house staff, know what they need to be doing based on different alerts that come. So that's a really, really quick whirlwind trip through effectively governance structures that we need to think about when we're working in this space of IPC. What I want to do now is actually take you through each of the components in your accreditation standards that actually reflects IPC, with the purpose of you then knowing what you need to be focusing on and which criterion you're pulling out from the IPC perspective. So a little recap on accreditation. We know, like I said, that you're assessed on meeting the mandatory RACGP standards, the 5th edition, and demonstrating continuous quality improvement. Accreditation cycle normally is a 3-year cycle, and you have your self-assessment audit that you submit prior to your on-site visit. But the whole purpose of that self-assessment audit is to enable your practice team the time to identify gaps and address those gaps prior to your survey visit. The practice I work in, we were recently assessed against the 5th edition standards, and I can't reinforce how, strongly enough, how important it is to be organised. There was something that we were missing on the day. The surveyors were able to ask us if we had that. We were able to pull it out and give it to them. And so, there was none of that run around post a survey visit. So that having time to prepare, not trying to do it 6 months before, but using that continuous improvement and documenting that is really, really critical. So we've got 3 modules effectively in our 5th edition standards. And what I want to do now is break down these for you. So we've got our core model, we have our general practice model, and we have our quality improvement model. Now, believe it or not, there is IPC components in every single one of these modules. Most sits within the GP module, but in saying that, you need to make sure you're meeting the others. So let's have a look. So in our core standards, we've got core standard 3 that talks around practice governance and management. And we have core standard 8 that talks around education and training of non-clinical staff. In our quality improvement module, we have the QI standard 3, which talks around clinical risk management. And then in our general practice module, we have our GP standard 1, where we talk about access to care. We have GP standard 4 that looks at reducing risk of infection. That's a bit of a dead giveaway, that one, isn't it? And then we have GP standard 5 that talks around the medical practice. So let's unpack these for you. So core standard 3, the criterion is you have an emergency response plan. So your indicator talks to your practice has an emergency response plan for each unexpected event, such as a natural disaster, pandemic, we know it well, or unplanned absences of clinical teams members. Now that one's been quite challenging, hasn't it, over the last few years, particularly with staff going off sick. So in this space, we need to make sure that the practice has a complete and appropriate emergency plan, including the practice's policy on infection control. And RACGP actually has one of these that you can use. So it's not something that you've got to, reinvent the wheel and think about, how do I do this from scratch? Reach out and utilize the resources that are available. Criterion C3.5 is around workplace health and safety. And that's around you looking at having the practice team is being encouraged to obtain immunisations recommended by the current edition of the Australian Immunisation Handbook based on their duties and immunisation status. Now, we get a lot of questions around this one. The big secret here is having a look at your Australian Immunisation Handbook and seeing what the recommendations are for the staff that you have and the duties that they are conducting. You must record natural immunity to vaccine preventable diseases or immunisation status of every single team member that you have. Now, these things would be something that you would be doing when you're onboarding new team members, but also you've got a policy around it and you need to make sure that you're reviewing it at least annually, particularly with your COVID and your influenza vaccines. You also need to make sure that staff members' immunisations, like I've just said, are appropriate to their duties. So, your admin staff might require or will require different vaccines to what your clinical staff are requiring. But then again, you might have some admin staff that are doing some high-risk IPC duties. And so, in fact, you would be offering them some additional vaccines. You need to make sure you've got this recorded really, really well and that it's always up to date. The next standard is Core Standard 8. And here we're looking at education and training of non-clinical staff. So you need to make sure that your non-clinical staff complete training appropriate to their role and to your patient population. You must provide evidence that non-clinical staff are provided with the relevant training. So this comes down to your training records. And as we've already identified, infection prevention and control is everyone's business. So you must make sure that they have the appropriate training. And that might be things like PPE, making sure that they're, depending on the status at the time, that they're using the appropriate PPE. But certainly there's a greater list than that. So you have a think about what must those staff be trained in order to ensure that they can complete their role safely and competently. I have put the coulds on the screen as well. I'm not going to go through those because they're suggestions around some other things that you could do in this space. But in regards to the must, there's no negotiating. You have to have these things in place. So if we go on to the QI standards now, QI standard 3 talks around managing clinical risk. Now this is quite a big one because this is about your practice monitoring, identifying and responding to and reporting of near misses and adverse events in your clinical care. Now, it doesn't have to have been an incident to report it. Near misses are great learning opportunities, and that's where we need to intervene and actually make sure that, we document that. I had an example, the previous webinar last week, where a participant said to me that they actually do this for wound infections. And so they record if they have clients coming back with an infection in a wound, or if they've done an excision or something like that. And they're able to actually see if there's any patterns and review that. And I just thought that was a great idea, both from a quality improvement perspective, but also from potentially a near miss. It also talks about your practice team making the improvements to your clinical risk management system to prevent near misses and adverse events in clinical care. And so it's around having systems and processes in place to support your infection prevention and control. So you can see there's no musts, but certainly if you don't have a register, you will certainly get a notification. So think about how you're doing that and how you're recording it, because it needs to be accessible by all, so that it is recorded in a timely manner and then followed through from your evaluation. Under GP Standard 1, we talk around being responsive and having a system for patient care. So it's about managing cross-infection through triage. And so, this is a very obvious one that sits particularly with your front desk staff. So it is around minimising exposure to other patients and your practice team. And I think to some degree that's probably been the area that pre-COVID wasn't quite thought of to the extent that it needs to be. So it's around implementing an effective triage and appointment scheduling system, determining and applying the appropriate transmission and or aerosol-based precautions to adopt, in addition to your standard precautions, because that's really critical, okay? It's around implementing your distancing techniques, which we've all got very good at, such as spacing your patients out in your waiting rooms. We also talk around adhering to the use of both standard and transmission and or aerosol-based precautions. And home visits are also included in this space. So it's not just about clinic time. So you've got to think about how can you address this from an IPC perspective to make sure that you've got a responsive system to continue to provide that patient care in a safe way to reduce the risk of cross-infection. It's a very, very big point on triage there. Now, this is the big one. This is where the majority of our components sit. So GP Standard 4 is all about reducing the risk of infection. And so your practice must have a system that reduces the risk of infections. The first one that comes into play here is around infection prevention and control, and including your reprocessing of your reusable medical devices. So your practice has at least one clinical team member who has primary responsibility for, and you can see quite an extensive list there, coordinating prevention and control of infection, coordinating the provision of an adequate range of sterile equipment, and that is both reprocessed and or disposable. Where relevant, having procedures for reprocessing, so that's including your sterilisation of instruments either on-site or off-site, and ensuring there is documented evidence that this reprocessing is monitored and has been validated. You need to make sure you've got the safe storage of stock and stock rotation of all your sterile products, and considering your waste management in this space. Now, I mentioned earlier that the AZNZS 4815/2006 is under review, and that it is pending that revision to be superseded. Like I said, we've tried for probably 12 months now to get a date on that, and they still can't give us a date. But I guess the really big thing here is to point out that the guidelines, we do talk quite strongly around reprocessing of reusable medical devices from the perspective that you must ensure that staff involved in reprocessing have received adequate education and training and regular competency assessment, so that that these are all documented, because your surveyors will look for that documentation. So while we recommend qualifications for reprocessing, there's actually no minimum requirement, believe it or not. It is, however, essential that staff responsible for reprocessing of reusable equipment completely understand the task, know exactly how to perform all steps, and have immediate access to clear and comprehensive instructions. And they can be relied upon to follow them completely. It is their responsibility for reprocessing tasks and must not be delegated to administration staff or other staff without first providing adequate initial and ongoing training. So it's not about a sit forget. You've done some training once, and that's all you need to do. It is very much around continuing that education and training to ensure that it's up to date. And I'm sure we'll get questions on this because we always do. But just remember too that for reusable medical devices, you need to be ensuring that you check your information provided by the manufacturer on the validation or the validated process for cleaning, disinfecting, and packaging if required, and sterilisation. So, that reprocessing is a huge, huge process. And so it's really, really critical that it's very clear in this space. You also need to make sure that you've got a designated area for processing of reusable medical devices, and that you must establish a workflow pattern that prevents the packaging and sterilisation and storage areas becoming contaminated. So it needs to involve a systematical process of moving from dirty to clean within designated areas. And a reprocessing area should always be separate from your treatment room and admin areas. So really think about that. We've got some fantastic examples in the IPC guidelines, so go and have a look there. Remember too that your PPE must always be worn when you're reprocessing, and it may need to be changed between different stages. You also need to make sure that you immediately, after use of your reusable medical devices, are initially wiping those down and rinsing them to remove visible soiling. They should never be left soaking. They need to be thoroughly cleaned in an equipment reprocessing area before being sterilised. And there's been a bit of a panic around washer disinfectors. At this point, it is not essential. You can still do manual cleaning. Some people are using an ultrasonic cleaner, but if you're using an ultrasonic cleaner, you still need to be manually cleaning those instruments after you've used that. Or if you are using a washer disinfector, that may incorporate an ultrasonic cycle in that process. But like I say, you need to be making sure that those tools are also being monitored and validated in the process. So manual cleaning is still okay. It's just making sure that you have that process in place. You'll then see for this criterion that you must have at least one clinical member who has the primary responsibility for infection control and reprocessing. And you need to ensure that the practice team members' immunisations are documented. We always do this with consent, but you need to make sure. And I need to hurry up. So indicator 4.1b talks around the practice having written practice-specific policies that outline your infection control process. You must ensure, like we've already spoken about, that your manual is up to date. It is practice-specific around your IPC components, okay? It's no point just downloading it and then printing it off. You need to make sure that it very much relates to your practice. I've seen manuals where the names have just been changed to the clinic name, and that's not sufficient. So 4.1c looks at your practice having a clinical team member who has primary responsibility for educating the practice team about infection prevention and control. And again, you'll see the theme here. You must have at least one clinical member who has responsibility for ensuring that all members of the practice team receive appropriate education about infection prevention and reprocessing of medical instruments. So there's the theme and the need for that person or people, as I said, is really critical. 4.1d, all members of our practice team manage risks of potential cross-infection in our practice by methods that include good hand hygiene. So here's your little list of training that you must have in place. The use of PPE, triaging of patients with potentially communicable or infectious diseases, safe storage and disposal of clinical waste, including your sharps, and safe management of blood, body, and fluid spills. In my clinic, all staff have education on all of this because you never know when one of our admin team might be in a position that they need to support a clinician. We hope it doesn't happen, but at least if they've got that training, they've got the knowledge that's required. And so under this indicator, you must be able to demonstrate that the practice team members manage risk of cross-infection and ensure that your practice has adequate access to PPE and is safely stored, that everything is safely stored and disposed of when it comes to both our sharps and our clinical waste products. So I could also give us some hints on the sorts of things that we can do in order to meet this indicator. 4.1E, our patients are informed about respiratory etiquette, hand hygiene, and the precautionary techniques to prevent the transmission of communicable diseases. I think we're all very well versed on this now, but let me tell you, we go out and audit clinics and we actually start to see things like hand hygiene, the use of PPE, and the positioning of waiting rooms really starting to fall off. We're seeing toys appearing back in waiting rooms. They can't be cleaned adequately, so we shouldn't be having them. And so you must have an adequate policy on infection control. Now, a lot of these criterions, they actually do cross over. And so I don't want you thinking that, oh my gosh, we've got to take these all separately. You know, if you've got a great IPC policy, it will cover off quite a few of these. Under 4.1F, we're looking at the practice records and your sterilisation load numbers from your sterile barrier system in your patient's health records, so that when sterile items have been used and they've been used, that they are recorded against the patient's name and those load numbers in the reprocessing log or list. What we often see here is that clinics do a fantastic job at entering the load details or into the patient's records and into your sterilisation books, but there's actually no easy way then of saying that XYZ was used on patient A should you have an issue. And so, you know, there's a couple of ways of doing this. You can draw it up manually if you want to into, you know, an exercise book and have, you know, your pack number, the patient's name and the date, or you can do things like having an Excel spreadsheet that's accessible to everyone on a shared drive, so that, you know, everyone that uses something that's been sterilised can then go at that point in time. Yes, we still enter it into the patient's records, most definitely. And so, you know, we do have it recorded in 3 places, that means, but it's critical that you can very quickly and easily identify any breach and link it to a patient that could have we could have had an IPC breach with. The rest around this indicator are coulds, but again, giving you the hints. 5.1A, your facility is fit for purpose. Now, these ones we sort of go, they're a little bit airy-fairy, but in fact, when it comes to setting up and maintaining your practice facilities, you must consider the principles of infection prevention and control. And if you're in that lucky space of, you know, you're building a purpose-built site, this is really critical. IPC should be at the top and forefront of everything that we're doing here. So you need to make sure that that is the case. Small criterion, so to speak, in that way, but critical part when it comes to IPC. And then I'll be glad to tell you that our last one that has any IPC lens on it is GP 5.3A. And this really simply is around ensuring that there is some, well, not ensuring, but there is some equipment in your doctor's bags, if you have doctor's bags, that are dictated by principles of infection prevention and control. So you need to make sure that you are meeting those standards with your doctor's bags. It's something that quite often gets forgotten. I have seen it hidden in boots of cars when surveyors have come to visit, but certainly something that you need to make sure that you really are ensuring that you're covering your IPC requirements of. So that's it in regards to, you know, the things that we've got to consider and how we can go to the guidelines to pull out to meet those components. I thought I'd just do a couple of slides now on the IPC lead or coordinator's role. They're being called different things in different sites. But this slide here shows you a summation of really most of the things that I've just highlighted through the standards. And it talks to the fact that we have at least one team member. I would highly recommend that you play to people's strengths. And so that if someone has an interest in infectious diseases and doing your surveillance and monitoring of what's going on in your local area, or both the state and then nationally, let them take that role on. And then you've got someone else who's really interested in the reprocessing stuff. Yes, you still need someone that's overseeing and coordinating all of that, but it doesn't mean you can't share the load. The standards state that you must have at least, or recommend that you must have one team member that should be appointed as your infection prevention and control coordinator. And the list of their duties includes all of those things there: overseeing a comprehensive IPC program, assessing the risks of infection transmission throughout your practice, drafting and finalising the IPC policies and protocols. You might have someone that loves writing policies and procedures. Give it to them. Give them all the information and let them write it. Assisting, obviously, with your accreditation for IPC, reviewing your IPC protocols, organising training and education for your whole team, and maintaining that staff register, doing your environmental scans, like I said, your compliance, making sure that you're monitoring compliance, providing patients with education. It's still really critical. COVID hasn't gone. We still need to be making sure that our patients are aware. We have other infectious diseases. And then maintaining, obviously, and confirming that your cleaner complies with your IPC protocols. We see a lot of contract cleaners come in. We need to make sure that we have all their credentials as well as part of our policies and procedures and training logs. You will be asked for them. So just because they're a contractor doesn't mean. Similarly with if you're outsourcing your reprocessing, we need to have the credentials of those contractors and making sure that they're meeting the standards through the work that they do. And then finally, we often get questions around, do IPC leads require formal qualifications? The simple answer is no, they don't. I hold a grad cert in IPC, and let me tell you, it just about sent me batty doing that through Griffith University. But there is lots of other opportunities out there to provide education. We do, however, state that they need to have an interest in IPC and the ability to develop the policies and procedures and commit to ongoing education to be able to manage the changes that we've all experienced in the past few years and that are not going to go away now. I have listed there on the screen just a short list of a few of the programs that are available. And while some states in Australia have requirements for practicing, if you're practicing as an IPC professional, to have a qualification, like I said, there currently is no minimum or standardised education in this space for you to be able to practicing in IPC or to even coordinate an organisational infection prevention and control program. The top one there, which you can see, is the Australasian College of Infection Prevention and Control. And they're the peak body for IPC professionals in Australia. That they do cover office-based practice. I was lucky enough to present at their conference in Sydney in November last year. They do have a day at the start of their conference that's all around office-based practice and implementing IPC standards. And so they do recommend that healthcare workers do some sort of training if they are working in this space. It's a short course, it's all online, it's self-directed, it's a fantastic course. So if it's something that you're thinking of. The National Hand Hygiene Initiative has so many short modules on their site. And there's also the Infection Prevention and Control Advanced Education modules through the Australian Commission on Safety and Quality in Healthcare. The last one there is the Mayfield Education. They do one-day workshops on sterilisation. And so if that's something, generally speaking, most of the courses you'll find around sterilisation are a Cert 3 level because they are designed for hospitals, not for primary care. APNA is working on this space and doing some education at the moment around reprocessing, so watch that space. But certainly if it's something that you want to look at sooner rather than later, have a look at Mayfield and see what they've got on offer. It's now 10 to 7. So the next slide really is just for you to be able to take away and access some of the resources that I've spoken about tonight, and you'll get that as part of the recording. And just to let you all know that the RACGP, three of the nurses, three of us who were worked on the revised guidelines, we are presenting in March. We're going to far more than what we can do in this webinar, but we're going to really break down over a couple of hours every component. So the high level components that I shared with you up front around the guidelines, we're going to break those down a little bit more and point out some of the things that you can really sort of hone in on. Probably 50% of it at least will be a repeat of tonight, but we will provide some sort of further opportunities for you to implement those guidelines. And then finally, I just want to say accreditation is really not about failing a practice. IPC is everyone's business, but at the end of the day, your surveyors are there to help you identify non-compliances. And then you've got the time to submit that further evidence. IPC, we know, is top and centre of what they're doing in this space at the moment. And I don't think that's a bad thing. I really don't. But please, there's lots of help out there for you. So please don't get alarmed and just reach out, but give yourself plenty of time to prep. My contact details that Aya will have. So reach out to them first and foremost, and then we're here to support you should you need anything further. And for those APNA members, you can actually also go through the nurse support line for IPC questions as well. Other than that, that's it.
Yeah. Thank you, Sarah. That was a fantastic presentation. We've had a few questions that did come through. So the first question we've had is, does the individual giving the training needed for reprocessing need to be clinical, or can they be administration?
So if we go, let me jump back to the slide around, let me see if I can find it, your reprocessing. The biggest thing here is that the person that is doing that reprocessing has received the appropriate training. So if your policy and procedure states that it's an admin person that's doing that, they need to, you need to ensure that they have received training and that they've got ongoing competence. We obviously, for obvious reasons, highly recommend that it is a clinician that actually works in this space, but this, the guidelines state that it actually does not have to be a clinical person.
Okay, thank you.
It all comes down to training.
Yeah. Okay, we've got another question. So are you able to sign a conscious objection form for vaccination? That's
going to come down to your individual practice in regards to what the requirements are, okay? So if the policy and procedure of the organisation is that you must be vaccinated against A, B, C, D, COVID's a really good example there. There's actually no legislation now that states the number of vaccines that you must have. It's highly recommended, definitely highly recommended, but there is definitely nothing that states that you must have them. So we recommend again that you, in fact, I think the next slide is around, we recommend that you do have the appropriate vaccines, but I can't say, based on the clinic that you must or must not. If the clinic's happy for the individual to sign a conscious objection form, then that's fine. My only advice there would be is that you would need to then consider, particularly if there was a high risk scenario of infection, so of an infectious disease, or let's say you've got someone that's come in with measles and the individual's not vaccinated against measles, you would need to think about how you might deploy that person to a different area of your organisation in that instance. You certainly wouldn't have them going in and into the isolation room, and then cleaning the isolation room once that individual's been in there.
Yeah.
So it all comes down to your individual practices, governance, and policy and procedure.
Okay, thanks. Another question we've received is, facility fit for purpose, how do practices with carpet pass accreditation?
Look, carpet is a tricky one. And in fact, under the guidelines, it is highly recommended that you don't have carpet or fabric chairs because you're not able to clean them. If you do have carpet, you need to be following the guidelines for cleaning those carpets, which includes things like having HEPA filters on your vacuums.
Okay. We also have another question. For accreditation, who in the practice needs to have done the hand hygiene course?
Everyone.
Okay.
Absolutely everyone. Hand hygiene is everyone's business. You know, you can't walk out from behind the reception desk and not be touching things, yeah? So that one, at a minimum, everyone must have done.
Okay. Also, another question, please recommend a IPC resource for education of non-clinical / admin staff.
So my recommendation is here, your National Hand Hygiene Initiatives or the Infection Prevention and Control modules. These are all designed for both clinical and non-clinical staff.
Awesome. We have another question around instrument reprocessing. The question is there no minimum requirement for training? Surveys usually ask for a certificate in instrument reprocessing. How do you answer that to the surveyors?
As in the surveyors ask?
Yeah.
I have not experienced that personally. Under the standards and the guidelines, like I said, there's no formal qualifications required. It's highly recommended.
Okay.
Okay. And so you just need to look in your local area around what are the opportunities to actually ensure. You know, some companies provide reprocessing. Just remember though, we talk reprocessing, we don't talk sterilisation.
Okay.
Sterilisation is one step in the process. And so training comes down to all of the different training that's required. I personally haven't come across any example where a surveyor has asked for accredited training in that space. I do know that a lot of general practices are sending one staff member to do accredited training because that's all we've actually had. But I'm definitely not aware. Certainly happy to follow that up if we can get the details of that.
Yeah. And then one final question is, can a practice manager train receptionists on infection control?
If they've got the appropriate skills, knowledge and training, definitely.
Yeah.
You know, infection control, like I said, is everyone's business. Look, it's probably my IPC qualification. I would suggest that you should have a clinician overseeing that because at the end of the day, the practice manager still needs to be trained by someone. Mm-hmm. Okay, they're not a clinician, so they need to be deemed competent as well, which is why I say you need more than one person in your clinic taking on the role because I can't assess myself. Yeah, my colleague that I work with, registered nurse, she assesses me. I could definitely, and I do all the training in my clinic, but I still need to be able to be assessed. Yeah. So definitely there's a part to play for everyone.
Yeah, that's a great answer. So thank you, Sarah, for presenting tonight, and thank you everyone for attending. Please remember to complete the evaluation survey. We appreciate your support. And also please visit our website to view upcoming events. Our website will be updated constantly with new events. And we look forward to seeing you at our upcoming events. Good night, everyone.